Okay, let's talk about something other than pregnancy, which I know some of you are ready to do. Okay, how did you feel about the exam? Did you feel confident going in? Pretty confident? Okay, good, good. All right. So when I get done here for this class, I'll be pushing the exam. So you should see it in ExamSoft shortly after class. All right. So let's talk about puberty. What is puberty? Who wants to define it? I mean, what do you think it is? What do you perceive it as? You're just worn out and don't want to listen to anything, do you? You want to call it, it's Friday. Man, it's hard to stay here. Right, Passion? You just want to go back to bed, don't you? Okay. Stephanie, you going to turn your video on? Or are you still getting something to drink? There you are. Yay. Okay. What is puberty? Well, it's the change in the hormones. They become active, right? So then we see some outward physical signs. So let's figure out what those are. So thelarchy, the very first sign in a female that hormones are now increasing in the amount and the development of breast buds. Okay, so thelarchy means breast buds. We see this anywhere between 7 and 19 years old. Okay, 19 is a little old for this to happen, but you can see in this picture how it changes over the years. We are concerned when there is no thelarchy after 13 years old. Usually when a woman develops breast buds, 2 years later, she'll start her first period, and that's called menarche. Okay. So if menarche is delayed, if a young teen at 15 years old has not had a period yet, we're concerned about that. Okay. Something else is going on. Okay. Or if she develops thelarchy, but then there does not have a period, then within 5 years. So what can be the causes of abnormal development or abnormal signs of puberty? Now, you don't have to know the Tanner stages for this class, but you'll have to know it for pediatrics. So breast buds is stage 2 of Tanner stages. Breast buds develop, the areola has a little bit of darkening, okay? A small amount of pubic hair at this point as well. And every woman goes through it at a different rate. So why don't they have periods? What's a primary cause of amenorrhea? Okay, A means without. Okay, so menorrhea is bleeding. So there could be something as simple as an outflow tract obstruction. Okay, surgically we can fix that very easy. Most of the time it's an endocrine issue. Somebody put something in the chat here. Let me look. Okay, pituitary gland dysfunction is what Miranda says. And that is true. That is the endocrine system. Hypothalamus is communicating with the pituitary, which communicates with the ovaries. Okay, so other things, polycystic ovarian syndrome is a phenomenon that some women have. It's excess androgen. They tend to have high levels of estrogen and low levels of progesterone. And these women are at risk for developing insulin or insulin resistance, diabetes, and then heart disease. You'll also see low thyroid levels in these women. So treatment for PCOS is a combination of things. Assessing their thyroid, putting them on thyroid. Sometimes we put them on birth control to level out the make their periods regular because most of the time it's irregular. Okay. There's other genetic reasons, and Fragile X is one. It's a gene that delays or interrupts the ovarian production of estrogen. And then, of course, Turner syndrome is a chromosomal disorder that we talked about. It's the sex chromosome. Chronic diseases can affect menarche. Medications, in particular opioids. Okay. And of course, contraceptives is going to cause, a lot of them can cause amenorrhea. And that's not necessarily a bad thing. Okay. And then, of course, a secondary cause would be just pregnancy. So here's a picture of the hypothalamus gonadotropic amenorrhea axis. We call it an axis because it's a balance. Okay. The hypothalamus communicates with the pituitary gland, and it sends out what's called a hormone called gonadotropin releasing hormone. And that goes to the anterior pituitary, and it releases FSH and LH, which are more hormones. And that goes to the ovaries, which spits out then estrogen and progesterone. Okay, you don't have to know this. Premenstrual syndrome. Some women experience this right before a period, hence premenstrual, during that luteal phase, right before she has a period. It's a cluster of things, physical as well as psychological and behavior symptoms. She tends to retain fluid, bloating, edema, some emotional change, a little more irritability, maybe craving certain foods. And so what if I have a client come in and tell me they just have PMS really bad? And I talk to her about, well, what's she experiencing? And then we talk about, well, what's her diet? What is she eating? What's her routine? Is she exercising? Just asking her about her lifestyle, and some of those things can be adjusted to help. We can also use estrogen and progesterone to help stabilize it and reduce those symptoms. And I'm a real proponent of contraceptives in the reproductive years because they are very beneficial to just control bleeding and make a woman feel like she has control over her reproductive life. And also birth control pills can help prevent against cancer. You've probably heard the opposite, okay? But they can help prevent cancerous situations and certainly prevent unwanted pregnancy. So it's like it should be routine for a woman to have a certain method of contraception to just protect her from unwanted pregnancies. I think there's a lot of myth out there, but they can be very beneficial. There's a more severe disorder for premenstrual syndrome. It's called premenstrual dysphoric dysphoria disorder. So it's a psychological disorder. It's just worsening symptoms of PMS. And it's just an exaggeration. So once again, we would do the same thing, asking her about what's going on at home, what's her lifestyle, what is she eating, any exercise, what other medications is she taking? And then we might give her some nutritional recommendations, maybe some over-the-counter stuff, and then some psychotherapy, or maybe even put her on not only a birth control pill, which might help, or some device, but also some kind of antidepressant will tend to help this as well. Anybody have any questions? You're just going to have to interrupt me. Okay. So some other terms to inform you about. Now, as far as your HESI, I've heard from students in the past said that there was a couple things on the HESI from chapters 4 and 5. One, it was about contraception, most of it, but I don't know. I can't tell you how much of this is important, but I'm trying to stress what I think would be something for you to know. So dis, that uh, prefix, dysmenorrhea, is pain, okay? Just like dysuria. So dysuria is painful urination. So dysmenorrhea is painful periods, usually right before a period or during the period, okay? And usually if I have a client that comes in with painful periods, my recommendations are, if she's smoking nicotine, then she needs to slow down. That might help. Reduce caffeine a little bit and exercise. And then she can use naproxen is superior to ibuprofen for menstrual pain. For some reason, it just seems to work better. Heating pads, maybe increasing calcium intake sometimes tends to work. Um, and then oral contraceptives or some other device. Okay, so so it's the prostaglandins. Remember, we've talked about prostaglandins. Prostaglandins are natural hormones that are released different parts of our body. They increase during labor, okay? When in and during a period, they're in higher numbers. So during a period with the prostaglandins floating around, yes, the uterine arteries are contracting, those little tiny arterioles, so it reduces blood flow to the uterus. And that's what causes pain. Just like coronary artery disease, when blood, because of either spasms or blockage, the heart muscle doesn't get the perfusion of well oxygenated blood, and it's called ischemia or angina, and it hurts. Okay, the same thing is going on during a period. It's painful, sharp pain. So we can give antiprostaglandins. So that would be the NSAIDs. Of course, exercise is going to help improve blood flow too. So other kind of dysmenorrhea, painful, is something else going on. Okay, and we most of the time we think of either pelvic inflammatory disease or endometriosis. Okay, so endometriosis, I have some pictures to show you if you're not familiar with that. And then pelvic inflammatory disease is a woman that comes into the emergency room and she's reproductive age and she's hurting so bad. And it's terrible, but we stereotype these clients thinking she's reproductive age, especially if she's a teenager or early 20s. We are assuming she's got an STI and that's why she's hurting. And she probably has more than one kind. So they prophylactically treat every woman, just about every woman that comes in and complains about a lot of pelvic pain with medications to treat gonorrhea and chlamydia. Okay, so let's talk about some of these things.
Sounds like a good way to create a superbug.
Well, yes, you're right. Yeah, you're right. You're exactly right. I think we're getting better with our antibiotics because now we're realizing with the studies that they don't have to take an antibiotic for 10 days. It might only need 5 days, and that sometimes helps. Like a urinary tract infection, you don't need to take medication, an antibiotic for a week. You can probably get away with, of course, it depends on your age and everything else. But so that was a good point though. So one thing that causes a lot of pain is called endometriosis. So endometrium is what we call the inner lining of the uterus. And it builds up through the menstrual cycle, then it sloughs off and that's the menarche or the menorrhea. Sometimes some of that endometrium will escape and find its way out around the uterus, around the ovaries, maybe even on the colon, the pelvic wall. They're called implants, and you can see them in this picture. If you look closely, let me see if I can enlarge it. The little tiny red areas, they're called implants, and they're endometrial tissue, and it causes a lot of pain. So the only way to diagnose endometriosis is through a diagnostic laparoscopy. It's the only way to diagnose it. And then we can go in there and we can actually burn them. We cauterize those little implants and destroy them, and that helps reduce pain. So that's the only way you can actually diagnose endometriosis for sure. So she's going to have pain all the time, not only during period, but even between periods. And it's going to be very deep pelvic dyspareunia, means painful intercourse. Okay, so we treat this with surgery if we have to. And then, of course, we can also put her in menopause, block estrogen completely. Of course, that's kind of rough, but if we do it for a cycle or two and then stop, sometimes that gets control of all the implants. And then, of course, the oral contraceptives then to reduce estrogen. All right, so here's just another picture of it. And during a laparoscopy, you can see it. Okay. So these are just terms, and you probably don't have to know these. Oligo, or small amount. Remember we talked about oligohydramnios, low amniotic fluid. So oligomenorrhea means periods are maybe 1 or 2 days, and that's it. And then just heavy periods. What is that? Menorrhagia. Metrorrhagia is irregular. So if we have a woman that comes in with painful periods, maybe they're irregular, we just call it now, the code, the ICD-10 code is dysfunctional or abnormal uterine bleeding. Abnormal. Used to be called dysfunctional, but now we just call it abnormal. And a lot of it is from leiomyomas or fibroids. Usually fibroids don't start developing in the uterus or on the outside until upper 30s. They're estrogen dependent, okay? So that's what causes the growth. So we can treat these. I had a client that actually had a couple fibroids. They weren't huge, and she got pregnant, and she had a pretty painful pregnancy. She was able to carry it to full term, and we delivered the baby, and then she had those removed afterwards. And so HPV Gardasil might be something you're asked on, HESI, and for sure probably the NCLEX. So Gardasil is the name of the vaccination that we can give to a person as young as 9 years old. And now the guidelines say we can give it up to 45 years old. This helps prevent the effects of HPV, the human papilloma virus. It has over 100 strains. Okay, certain strains cause cancer, other strains cause warts, and other ones don't do much of anything. Okay, so strains 6 and 11 are what causes those genital warts that you might know about. And 16 and 18 plus several others, strains of HPV can cause cancer on the cervix. Okay, so vaccinating against it is a really good thing. Okay, so chlamydia is a very common sexually transmitted infection. It has long-term effects if not treated. We treat it when we have a client come in for their first pregnancy visit. We do cultures of the vagina just to make sure there's no bacteria there. And if we find chlamydia, we're going to treat it. It's only 1 dose of azithromycin one day, one dose is all. And then we're going to watch her throughout her pregnancy just to make sure she doesn't contract it again. And there's a lot of education associated with that because we need to have her partner get treated as well. Chlamydia is one of those infections that travel very quickly through tissue. So if she has chlamydia and she doesn't get treated and it's been over a week or maybe even 2 weeks, it could actually travel into her uterus, cause scarring, travel to the fallopian tubes. It can cause infertility because of the scar tissue. And certainly probably PID, pelvic inflammatory disease. And there's a couple pictures on the bottom here of genital warts from HPV 6 and 11, and then chlamydia. Gonorrhea is another one. That's it's something that's been around for a long time, and that's what we put in the eyes of the babies because we can treat it topically. So ask the question, why do we treat gonorrhea prophylactically and we don't treat chlamydia? Anybody know why? Why don't we think about chlamydia? Because it spreads rapidly during pregnancy. So why wouldn't we want to treat a newborn for chlamydia in case mom has it? You probably don't know. So chlamydia travels quickly, but it doesn't cause blindness, okay? So what will happen is mom will go home with her baby, and a week later, she's calling the pediatrician and said, my baby's eyes have pus on them. And so we immediately think of chlamydia, and we have to do oral medication for that. We can't treat it topically, okay? It doesn't cause blindness. It's just a lot of pus. So we don't want to make that assumption. And so we have to treat gonorrhea in case it's there because it will cause blindness. Okay. And then gonorrhea, of course, can spread throughout the body. Trichomonas, another sexually transmitted infection. It's easy to treat. These are all easy to treat. Gonorrhea, we treat gonorrhea with Rocephin, a cephalosporin, and it's usually one dose. We can give an injection, and that's all we have to do. And with trichomonas, we use metronidazole, and it's just all these tablets one time. And really important things about sexually transmitted diseases is that we have to make sure we're explaining to our clients, these are easily contracted if you don't if you don't be very cautious with who you have intercourse with and get screened every 6 months or so. Just go in for a culture. That's what's recommended by the CDC, especially if you have more than one partner. And then some of the states, and I don't know which ones for sure, but there is partner testing so that if I have a client that comes in, and I do this with pregnant women, they come in if they have chlamydia and she's pregnant, we'll treat her and I will give her prescription also for her partner. I don't have to see him. The law says I can go ahead and write him a prescription, but I really like for him to come in the next time when she comes in so we can talk about those things and so that they can be safe. And that's the whole idea. And then syphilis, old disease, is raising its ugly head again. Usually we see this in men who have sex with men. This is predominantly where it's diagnosed, or bisexuals. And so the scary thing about syphilis is that you can contract it and really don't know that you have it. You can have they call it chancre. It's on the lip or on the penis or on the vulva somewhere. It's not painful. Okay, and it goes away. So people think, well, that it's gone. But thing is, it's traveling to other parts of the body. Okay, so syphilis during pregnancy can cause stillbirth or miscarriage, an abortion, a spontaneous abortion.
And severe congenital defects if you've had it for a long time.
Pardon, Miranda?
It can also cause congenital birth defects. Like if anyone is curious, just look up syphilis newborn. It's insane.
Yeah, yeah, yeah. And then it's another thing that's easy to treat, and there's a protocol for it. Usually, if it's a primary infection, the first time a client presents with symptoms of syphilis, if it's a chancre, then we know it's the first stage, the first infection, and that's good because then we can give the penicillin injection, and that usually clears it. So in pregnancy, our goal is to keep the titer of syphilis down 1 to 8. I had a client that came in, her RPR was positive, so we did the second testing, and she had syphilis, and she didn't know anything about it. She didn't know she had it, so we had no idea when she got it. So usually, if it's unknown, if it's a latent syphilis, she needs 3 doses once a week, 3 weeks injection. And when I found that out, the obstetrician I was working with, he said, no, I think she only needs 2. Uh, and I called the health department I was in Tennessee. They said, no, 3. And I talked to the people next door and they told me 3. And he said, I don't think that's right. And he didn't double check. And I can't give it if he doesn't, he's my supervisor. Anyway, she ended up having a stillbirth, but it was probably too late anyway. But it's really a sad situation. So some babies could be also born with the rash on their hands and feet. It depends what stage of syphilis mother's in as to what will happen with the fetus if the fetus survives. And then there's a movie out, and I can never remember the name of it. And Bette Midler's in it. And it's about a woman that had syphilis. It was way back in the days, I think back in the 40s, 30s, something like that. And she contracted syphilis from her husband, who left and ended up dying. And we didn't know the treatment back then. And so it passed through her body and it went to neurosyphilis. And so you act a little bit like you're having a stroke. It was a really sad movie, but it was good. I can never remember the name of the movie. But anyway, so much for syphilis. And these are just more pictures. The neurosyphilis is on the bottom. You can see the little abscess there where those arrows are. And this is the PID I told you about. So just a lot of different microorganisms that are within the uterus, the ovaries, the tubes, even beyond that in the pelvic wall. So inflammation, and we usually have to use a combination medication. This is just another picture of it. So malaise, chills, a fever, vaginal discharge, elevated white blood cells. So PID can cause ectopic pregnancy because of the scarring, infertility, chronic pain. So treatment usually, and I haven't checked this in a year or so, but the CDC recommends we're making an assumption that our client has PID when she comes to the ER. So we're going to give her a cephalosporin injection, okay, 2 grams every 12 hours, and then we're going to give her oral doxycycline. Okay, or we can give 2 grams of cefoxitin IV every 6 hours plus doxycycline. So cefoxitin or cefoxitin. Those are 3rd generation cephalosporins. We're making presumptive that she has it. And then herpes, of course, is a virus. Okay, we find herpes 1 and 2 orally on the mouth, 1 and 2 on the genitalia. It's just all mixed up now. And yes, as HSV1 tends not to be as virulent or causes much problem as HSV2, but we still need to treat it during pregnancy. So if mother contracts herpes for the very first time during pregnancy, that's the worst case scenario. Okay. So it can cause all kinds of terrible things to a fetus. So if she has had it before and she gets pregnant, it's not as much of a problem. But if she does have a lot of outbreaks, recurring outbreaks, we need to treat it. I usually prescribe valcyclovir. It's an antiviral, and it will kind of suppress it a little bit. And it's just a once a day dose of valcyclovir. Acyclovir, you have to take it 4 times a day. And that sometimes will help. So just education, talking to our clients about safety. Condoms won't protect them. There's some pictures here of what it's like. This is the vesicles on the lower lip, and this is on vesicles on the penis. Yes, they're uncomfortable. And sometimes if there's a lot of stress going on in someone's life, they'll have more outbreaks. Peanut butter shots. What's peanut
That's what we
butter?
call bicillin. This is the consistency
Okay.
of peanut butter. We call it the peanut butter shot.
Okay. All right, I hadn't heard that one. Okay, so hepatitis B. So every woman is checked for hepatitis B active stage. Okay, so we check for the surface antigen. If the level of the surface antigen is high, then we're most concerned about it being passed to a fetus. So the important thing about any of the hepatitis is, and HIV, is where is the viral load? In other words, how much of the virus is in the body? So the higher the load, the more risk there is of passing it to the fetus. We can treat these viruses during pregnancy. So HIV is one that we can treat with antiretrovirals, preferably a person with HIV that wants to have a baby. Let's get her treated and get that viral load low, and then she can get pregnant and then continue to treat her to keep it low during the pregnancy, so there's little chance of transmission, and then she can deliver vaginally that way. But you know, someone with HIV in treatment, they're at risk for all kinds of infections. So we also, because they're immunocompromised, their immune system is being destroyed. So they're at risk for infections during pregnancy. So we have to watch them very carefully. And of course, you know that the AIDS syndrome is when the viral load is so high, and it really, really begins to damage and cause all kinds of problems. And I don't think any woman with high viral load is going to even be able to carry a pregnancy. So yes, we always have to get consent from our clients if we're screening for HIV. And it's recommended for people with high risk sexuality. In other words, they have multiple partners, to get checked every 6 months for HIV and other sexually transmitted bacteria. Okay. I think the rest of this, Zika. So I want you to, I don't think you need to know about all of this stuff. You can look through it. It's kind of interesting. In situ means it's still in one place. It's not spreading. That's what that means. All right. Any questions? So at what age does anybody know at what age a woman should get her first mammogram if there's no family history of breast disease? Anybody know? First mammogram should be when?
Is it
She
40?
should be 40.
40. 40, yeah. They're wanting to
every
push
year.
it to 45. They're wanting to push it to 45. And then at the age of 50, so every 2 years, okay? And then at the age of 50, it's every year. When do we do the first pap smear?
21.
21. How often does she need one? Does anybody know?
Under 30, as long as they're normal, it's every 3 years. Over 30, if they're normal, it's every 5. And then they stop at 65. Granted, you haven't had any abnormals in the last 20 years, I believe.
Okay, a hysterectomy, and if the cervix was removed, we don't normally recommend the need for a pap smear. Okay, the guidelines are based upon the results. So if we have someone with an abnormal pap smear and she has HPV, then we want her to come back in 6 months and check again. Okay, so it's very close monitoring to prevent any kind of spread of cancer.
So ours is similar to that, but it's if they're ascus, we do another one in 2 years. And if it's low grade, we usually do another one the next year. Or if it's high grade, or if she has one of the high risk HPV strains, we do a colposcopy.
Mhm, mhm. So there's an algorithm to go by. Not all providers follow it. Okay. We've got a little more time here. Let's talk about contraception. Infertility and we talked a little bit about infertility when we talked about amenorrhea. Okay. Okay. So endocrine reasons, okay, or just some kind of organ. The uterus has an abnormal structure. Okay? It could be the male partner for reasons that the couple is not conceiving. So here's some pictures of some abnormal uterine structures. The didelphys, which is the one on the right top, I had a client that had this, and yeah, she was able to get pregnant and carry babies. She usually delivered a little early. In this situation, there are 2 cervix, and we have to do 2 pap smears, right? 2 separate pap smears. But usually it's just one side that carries the baby, okay? Usually one side. The other side is usually not functional, at least as a uterus. So there's reasons for men not being able to have the ability to produce healthy sperm. Okay, might be a hormone issue as well. Remember Klinefelter syndrome, the chromosomal disorder? It's a trisomy. It's a sexual, an extra X on in his nucleus of his cells. So it's a hormonal factor. So sometimes it's opioids in particular, reduces sperm production. Sometimes it's just not having enough semen or the morphology of the sperm. The tail is too short. It doesn't move enough, things like that. So we go through, in infertility, we go through a lot of testing, a lot of questions to see. First, we start with the female. We're going to draw some labs and look at her hormone levels during her period, first day, 5 days in, and things like that. We're detecting any possible ovulation. Okay, so we're doing an analysis. We can do an ultrasound first to look at her anatomy, make sure everything looks normal. Then we can do what's called a hysterosalpingography. And this is where we actually insert a catheter into the uterus and inject dye. And so we're looking on the x-ray of the dye being spread through the tubes. It just tells us the patency of the tubes. If all of that is normal, then we might do a diagnostic laparoscopy. I had a daughter, my oldest child, had trouble getting pregnant. It was several years they were trying, and then we couldn't figure out why. So we ended up doing a diagnostic laparoscopy. And when they got in there, they saw a lot of endometrial implants on her ovaries. She didn't even know she had endometriosis. She had some painful periods, but not enough that ibuprofen would take care of. And so also near that time, we found out she also was a, uh, she also had Leiden factor five mutation. So it's a clotting protein that she has a lot of. So she makes clots easily. Okay, and that's another reason she wasn't able to get pregnant. So she did get pregnant. She had 4 children after that. So here is the setup. We usually make an incision just below the belly button and put a camera on a scope. And then if we have to do any instrumentation, in other words, if we need to cauterize or anything else, we'll make another incision on the belly and use another instrument. So we expand the gut with some CO2, and we have light source attached, and we can look inside the pelvis and see what's going on. And this is just about the male infertility, then what we can do. Kind of repeat myself here. Certainly, this is about the whole woman and the whole family. So we have to consider all the psychosocial and the economic status of our client, because when you get involved in infertility treatments or assisted reproductive therapies, most insurance companies won't pay for it, and it's very costly. So there's a little bit of barrier there for people who really don't have the money, that really need help with conceiving. So there's different kinds. You don't have to know these because I don't know them all. This is a video you can watch if you want to. It talks about assessment of fertilization. So they have pictures of what it looks like when the egg is fertilized. They're realistic pictures, kind of neat. And then how in vitro works. You can watch that. So, and then there's other things that we can do. We can do surrogacy. And there are agencies across this country that they actually have a registry of women that have been tested and because they want to be a surrogate. So we do all kinds of, or they do all kinds of testing to make sure they're healthy and they could carry the baby. And so they can be a surrogate. Okay. Adoption, which you all know about. And then your book talks about all these ways of fertility awareness, a contraceptive method other than hormones. There's different ways of doing it, and sometimes it works and sometimes it doesn't. I'm not going to go into all that stuff. And then the barrier methods. I think there was a question on one of the HESIs about the diaphragm, what it is, and the student said she had no clue what a diaphragm was. But there are barrier methods, and for the woman in particular, a diaphragm then would be a device that goes in the vagina and it surrounds the cervix. We put spermicide in that diaphragm, or you can a cervical cap is the same concept, and it fits more tightly on the cervix, and we're going to use spermicide. And then there's a contraceptive sponge. I think for a while in this country they had trouble getting a hold of one. I don't know if you see those on the market. I'm not even aware of them. I haven't worked in that field for a while, but once again, it covers the cervix. So it's really important that there's also a spermicide, some kind of cream or foam that goes along with it that will kill the sperm. And then, of course, there's hormonal contraception, pills, patches, rings, and IUDs. So some have estrogen, some just have progesterone. Most of the oral medications, if they have estrogen, they have to have progesterone. And some of them just have progesterone. And I can tell you that estrogen is a hormone that it's contraindicated for women that are older than a certain age. Okay, I would not give estrogen to a woman that smokes and that was in her 40s. She can have progesterone, it's going to work just as well and be healthy. I wouldn't give estrogen to a woman with a history of migraines or seizures. I wouldn't give estrogen to a woman with high blood pressure or heart disease or diabetes. Estrogen is uh, a hormone that increases the risk of blood clots. Okay, so we don't want to give estrogen to those women. We really don't want to give estrogen to women who are breastfeeding because it'll reduce milk production. Okay, we want prolactin levels to stay high. If we give estrogen, it's going to pull the prolactin down. Okay. Transdermal, and then there's injectable. So the NuvaRing is a combination of oral, or NuvaRing is in the vagina, progesterone, and estrogen. The nice thing about the NuvaRing, we can use it temporarily if a client, I had a client ask me, I'm getting married in May. I don't want to be on my period when I get married. And so we made a decision. She opted for the ring, so she could put it in before she got married and just leave it in for 4 weeks and then take it out and resume whatever she wanted to use, just to prevent her from having a period. Okay. And then there's the progesterone only. So if you have a client with a history of seizures, even some neurologists don't want them to have it. So we usually contact the neurologist, and if he says, yeah, she can have it, we can do progesterone only birth control. So there's the injection, the Depo-Provera, which, yes, a woman will gain weight with this. It's the only one usually. It's associated with weight gain. And then there's a subdermal implant that's we inject it. It's good for 3 years. Safe, easy to do. We just numb it up with a little lidocaine, and the device will actually inject it just underneath the skin in the subdermal. And so you can still palpate it when it's in. And then after 3 years, I make a little incision and it comes out. It's not hard to do.
New studies actually show that it's got a longevity than they initially thought. I believe.
Are you talking, Miranda?
Yeah, sorry, my phone's up. So
You're not very loud.
Can you hear me better now?
Yes.
So there's new studies on the Nexplanon that show it's actually good for up to 5 years, which is kind of cool. If anyone has it, who was that?
Yeah, and you know, that's just it. It's true about the IUD. It might last longer, but if the manufacturer says 3 years, then we can't take a risk and leave it in there, because we don't want, then our client would be very upset if she got pregnant. Yeah, until the manufacturer claims 5 years, we can't really do anything about it. But yes, that's true with some of the other ones too. So intrauterine contraception, the Paragard, it's a 10-year device. Doesn't have any hormone. It has copper, which is a spermicide. It kills sperm. Okay. It's good for 10 years. You see Paragard a lot in European and Middle Eastern countries where they don't want to use hormones. And then there's the Mirena or the levonorgestrel intrauterine device, and I'll show you pictures of these. Now these devices don't protect against any sexually transmitted infections, right? So Paragard is good for 10 years. Okay. She'll still have a period. Sometimes they're irregular. Okay. But it's very effective as a contraceptive. The Mirena or the hormone IUDs, you can see that white center, that's the hormone, slowly release progesterone. And this actually goes inside the uterus, very soft, made of silicone. And we insert it, it's good for 5 years. Clients love it if they can tolerate the procedure. It can be a little painful, but it goes away shortly after insertion. And this is what they say might be good up to 7 or 8 years, but we don't want to take that chance until a manufacturer says to us, this is a 8-year device or whatever. Okay. Emergency contraception, you've probably heard what's going on now with Walgreens not providing this stuff over the counter in Republican states. And it's just a mess out there. I don't agree personally or professionally with making things like this available over the counter. Okay, prescription, yes, but over the counter, no. But I think Walgreens is not providing it at all in certain states. So emergency contraception is an option. If a woman is raped or if someone has unprotected sex, and it just happened, right? We can actually give her some oral contraceptives to help prevent the pregnancy if we do it at least within those first 72 hours, preferably sooner. Okay, we can actually put an IUD in of some sort. Okay. My youngest person, I put an IUD in it was a Kylena. It's a little smaller than a Mirena, but but it's good for 5 years. She was 13, very responsible, came in with her mother, and her mother said, she told me she was sexually active. And of course, we have to make sure she's not pregnant and then plan. We usually put them in when a woman's on her period. The time is good as far as hormones is put it in during that time, and it's a little more comfortable for the woman because there is a little bit of dilation there. So and putting it in, a 13-year-old was the youngest I'd done, and she did super. And it is one of the most perfect contraceptives. Get on my bandwagon here and really promote IUD. It's very effective. A lot of women end up not having any periods with them for 5 years. And we can take one out and put a brand new one in when it's expired. So permanent sterilization would be actually going in and blocking the channels, right? So fallopian tube ligation or clamping or putting clamps on them. There's different ways they do them now. And then vasectomy. So it prevents eggs from being fertilized, eggs from traveling from the ovaries to the uterus. And a vasectomy prevents sperm from traveling from the testes to down through the penis. And each one of those surgical procedures can be reversed. We can re-anastomose them. In other words, connect them back, and it's very effective. They only usually do, for a woman, they only usually do one side. So in this picture at the top is a picture of a fallopian it's called bilateral fallopian tube ligation. And the one on the bottom, it shows a picture of the vas deferens. So we can cut it, and if the man decides he wants to have children, we can tie it back together. And then the rest of this is information about abortions. So we talked about some drugs that cause the cervix to dilate, and at higher doses, the uterus to contract. Okay. So first trimester abortion, we can use some of these drugs. If the woman's not very far along. Okay. Sometimes they can be pretty uncomfortable to do it that way, just a medical abortion. To give her some methotrexate and a prostaglandin to stop the growth of that egg and that zygote, stop the growth and cause it to be released. So there's different drugs we can use, or just doing it surgically, going in there and suctioning um, the zygote. So it can be pretty painful, and sometimes we don't get, or whoever's doing that, I've never assisted in abortion, don't get all the tissue out, and so they come in with infections, they come in with bleeding, pain. So we have to go in there and do a D&C or a D&E and clean out her uterus. So if this is an area you end up working in, do some self-reflection before you take that step. Know your state laws. It's always best to know what's going on in your state if you want to work in that area. So it's best for a surgical abortion or medical abortion in that first trimester. The longer you wait, the more complicated it becomes, the more risk for infections, excessive bleeding, and actual damage to the uterus, cervix, or the fallopian tubes. Scar tissue set up, and then she can't get pregnant. Another medication that we use let me see, to help women get pregnant, this is kind of stuck at the end, I should have had this at the very beginning, is clomiphene citrate. It's Clomid. And what it does, it helps women to get pregnant because it tells the ovaries to mature extra follicles. Okay. Usually the ovaries, there's one follicle, it's called the Graafian follicle, that will mature and be released as an egg. But if we give Clomid, there might be 3 or 4 eggs that are released. Okay. So if you have a client and I've prescribed this many a time, and it does work, okay, and she's very concerned about risk of multiple births. So as a nurse, what should your response be before she decides to walk in this direction? What is the best answer? What do you think is a good answer?
Wouldn't it be A?
Yeah, yeah. But it's not true that no one has ever had more than triplets with COVID. You might have triplets, but nobody's ever had any more. You can't say that. That's not true. Okay. Ovulation will be monitored with ultrasound. We can do that. Okay. But we can't prevent it. We can see it on the ultrasound, but we can't prevent it from happening. Okay. 10% is a very low risk, so you don't need to worry too much. That's not a good answer. Telling someone not to worry is never a good answer. Okay. She might be in that 10%. So it's best that she talk about, you know, more statistics. She probably needs more statistics. Okay. So this is how it's prescribed. Day 1 of the menstrual cycle, which is a 28-day average. So day 1 is the first day of the period. So on day 5, she takes a Clomid. Day 6, 7, 8, 9, she takes it. Okay. And then she stops. And if she gets pregnant in that cycle, that's great. If not, then she'll take it again the next month. So we give her 3 months worth, and hopefully she gets pregnant. If not, we can do another 3 months. Okay. So it's a selective estrogen modulator. It stimulates estrogen production, enhancing the development of a mature follicle, which is ovulation. Okay. If you're looking over these slides or you're looking in the book about all this, if you have a question, you can ask me. Okay, anybody have any questions? Do you understand how to register to take your HESI? They're all ready now for you to register. So you go into your Evolve account and it says HESI registration exams. Just look for the one that says RN maternity. It's the next gen. Okay. Anyone here at all that Proctor U? I don't think so. Oh yeah, Pensacola's Proctor U, right? Anybody here from Pensacola? No. Okay. So you're going to campus to take your HESI, right? Okay. Don't wait till you go to campus to register. Register early so you might have a better choice in time. Okay. Natasha, are you sleeping? Okay. All right. Thank you all for your patience. I will see you next week. Okay. And I'm going to get your grades out here. By Passion.
Thank you.
You're welcome, Joy T. Good job on the exam, by the way. I think you want to know what you said you're only you know what you got?
Yeah.
You got
I
them
don't
all
know.
right. You got them all
Oh.
right.
Oh, nice.
Yeah, nice, very nice. You've done really well this quarter.
Yeah.
Yeah, you got 100%.
Oh, that's great.
That's awesome.
Yeah. Thank
Yeah,
you.
you're
Thank
welcome.
you. Yeah. Bye bye.
Bye-bye.
Have a great day.
You too.